You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for August 19th, 2022. This week, the obesity paradox and atrial fibrillation. Paradoxes in general. Digital health gets whacked again, and direct-to-consumer advertising. Now, the first topic today relates to an important bias in making conclusions about cause and effect or correlation. I want listeners of the TWIC podcast to be forever alert to the word paradox when it comes to observational studies. But before we talk specifically about a study looking at BMI in patients with AFib, let me ask you to ponder this question. What if you were interested in the association between athletic ability and intelligence, IQ? Is there a relationship? Are jocks dumber? Now, what group would you study to learn about this association? In the lingo of epidemiology, what group would you condition on? Now, let's say you decided to study individuals who attend an elite college. Let's say the University of Virginia. The lingo here is that you condition on being a University of Virginia student, UVA student. Now, the problem, of course, with this is that to get into an elite school like UVA, you have to be either really smart or really athletic. So now perhaps you can see the problem. If you then look at athletes at elite schools, they will likely be lower in IQ than the regular students. Therefore, you will find a falsely negative association between IQ and athleticism. However, if you looked at this question in the general population, there's probably no relationship. Okay, with that question, let's now go to the specific study. This was the journal Open Heart, a BMJ journal. They published a paper looking at the influence of BMI on outcomes in patients who had atrial fibrillation. This paper offers the TWIC podcast an opportunity to speak about one of the most important biases in observational studies, and that is selection bias, or in this case, selection bias due to a collider bias. This is really important. There have been more than 3,000 articles on the obesity paradox and cardiovascular disease. And all of these studies that I have looked at are marred by systemic bias, and collider bias featured prominently in the COVID era. For instance, there were COVID papers showing that obesity in ICU patients with COVID pneumonia seemed protective relative to normal weight, another paradox. So for this particular study, the authors used the Garfield Registry, which is a registry in Europe of more than 52,000 newly diagnosed patients with AFib who had at least one stroke risk factor. Patients were enrolled and followed over time from 35 countries. In other words, the authors conditioned on having AFib. And for this particular study, they broke down 5 BMI groups: underweight, normal weight, overweight, obese, and extremely obese. The main clinical outcomes were death, stroke, bleeding, and heart failure. Now, before we get into the results, stop and think. Here they are recruiting people with a problem, AFib, and they're studying the effect of a cause of that problem, obesity. The main findings were a U-shaped relationship between BMI and the heart outcomes. Both low and high BMI were positively associated with events. But here's the kicker. The lowest risk of all-cause mortality was observed at a BMI of approximately 30. Below 30, there was a 32% higher risk of mortality per 5 kilograms per meter squared lower BMI. Above 30, there was a 16% higher risk of mortality per 5 kilograms per meter squared higher BMI. Now pause there for a minute. They are saying that it is worse to be normal weight than have BMI in the obese range. They report that a BMI of 30 thought to be obese had the best outcomes. You had higher risk as you went down in BMI. A person with a BMI of 24, which is normal weight, had higher risk. Quote, our findings support an inverse relationship between BMI and risk of death in AFib, but only for BMIs less than 30. They speculate about this funny paradox because they say the greater BMI has been associated with more risk of high blood pressure, diabetes, coronary disease, which then turn into risk factors for mortality and heart failure. I mean, we never tell normal weight AFib patients to start eating Cheetos and drink pop to gain weight. So my friends, whenever you see the words paradox, always be on alert for this collider bias, a form of selection bias. This is a classic case, as is every study I have seen with the word paradox in obesity. Now, I'm going to link to the University of Oxford Catalog of Biases where they describe the first case of collider bias from none other than David Sackett himself. But in this case, in this study, consider the two ways to get atrial fibrillation, which is to get into this study. Yes, obesity is a cause of atrial fibrillation, but then consider the other causes of why normal weight individuals might get AFib, say pulmonary embolism, alcohol abuse, cancer. These other causes of AFib may be more sinister a cause than obesity. And if you only look at AFib patients, you find this false or paradoxical relationship between obesity and AFib. Obesity looks protective relative to the other more sinister causes of AFib. Now, I'm going to link to another great example, a paper I want you to read. This is a paper from Steven Stovitz, and it's in the Journal of Epidemiology and Community Health, and I'll link to it. It's a BMJ journal. Stovitz is an expert on collider bias, and I lean on him a lot. And we've written a letter to the editor in the past on one of these paradoxes. And a lot of what follows in this few comments I have is thanks to Steven. This paper that I'm going to link to, he and his co-authors Jay Kaufman and Haley Bannock purposely set out to show that a study can look great and be purposely biased by collider bias. So they went to the University of Minnesota database and they took a cohort of kids who had had a hemoglobin A1C level tested at their university. So they conditioned on having a hemoglobin A1C test. He then divided this group up into weight categories, underweight, normal weight, and obese. And they found that when you restrict the sample to only those individuals who get hemoglobin A1C test, obesity was protective against diabetes. Normal weight kids had 8 times the risk of having a positive hemoglobin A1C compared with obese individuals. This is a brilliant paper because they did it on purpose to show the effects of collider bias. They tried to get it into the BMJ Christmas Journal but were rejected. Their paper had all the appearances of a high-quality paper. It was conducted at an academic center. It was abided by the Strobe checklist. It had a diverse group of urban and rural kids, and it had large numbers and low p-values. But it was purposely biased to make a point about collider bias. The exposure in their paper was obesity, the outcome was an abnormal A1C or having diabetes, and the collider was getting a hemoglobin A1C test. Think about it. You only got in this study if a clinician determined that a blood test for hemoglobin A1C should be obtained, meaning that they had some type of clinical indication to warrant such a test. And there were basically 2 reasons. Now, many clinicians will draw an A1C when evaluating obese children and adolescents because that's what the recommendation is, to consider testing for diabetes. But clinicians also draw a hemoglobin A1C test when children have symptoms of diabetes and appear ill, regardless of body weight status. This is the key to understand the selection bias. Ordering the A1C is an effect of either being obese or appearing ill with symptoms and signs of diabetes. And that is what leads to the spurious association. Those who had the A1C test because they appeared ill were much more likely to have diabetes than simply being obese. Thus, obesity looked protective against diabetes, which is foolish. Now, in the case of the Garfield registry study that I told you about, we have the exposure, obesity, which can cause the outcome, death, stroke, heart failure, and the third variable or collider is AF. In other words, the people with AF who did not have a high BMI as a possible cause must have had something else as a possible cause, or they wouldn't have had AFib. And that other AFib causing illness is what causes the lower weight AF patients to have a higher risk. Now, the authors mention all this in the discussion, but it did not affect their conclusion. And you all need to know about this bias because it's a threat to evidence-based medicine. It is a systemic bias that lies hidden in all of these papers. And get this, in 2016, JAMA published an RCT looking at calorie restriction on VO2 max in obese patients with HFpEF. First author is Kitzman, and I'm going to link to that paper as well. This trial found that weight loss improved VO2 max in patients with HFpEF. It was a positive finding in their primary endpoint, and HFpEF is no easy condition. But here's what the authors wrote in the discussion section. Quote, because of the reported heart failure obesity paradox, which is lower mortality observed in overweight or obese individuals, before diet can be recommended for obese patients with HFpEF, further studies likely are needed to determine whether these favorable changes are associated with reduced clinical events. This is in JAMA. And heart failure with preserved ejection fraction is tough to treat. We have a positive study. Of course, overweight patients with HFpEF do better with weight loss. So, my friends, whenever you see a study that describes a paradox, look at the population studied. It is, in every instance that I've come across, a selected population. Like those UVA students, you're trying to figure out intelligence and athletic ability. These studies are all marred by a systemic error of selection bias. And a word to journalists, when you come across one of these purported paradox studies, look up Steven Stovitz at the University of Minnesota, or Jay Kaufman at McGill, or Haley Bannock at the University of Toronto. Get them to comment. They have all written extensively on collider bias. All right, next topic, digital health. JAMA Internal Medicine has published reports of an RCT led by researchers at the UCSF looking at the efficacy of a self-measured blood pressure cuff that connects to a smartphone versus a regular self-measured blood pressure cuff. Now, the idea is thus. Blood pressure is a big problem, and guidelines recommend self-measured blood pressure. Heck, so do I. It's really important for getting good measurements. You probably do too. Yet simply measuring blood pressure at home does nothing. You need feedback and action on these numbers. Now, devices that enhance standard self-measured blood pressure with additional digital support from a paired or connected smartphone application are commercially available. These apps interact with patients, and they don't require health system involvement. The translation, it makes sense that such an improvement would lead to better blood pressure control. Well, regular listeners of TWIC podcast know that things that make sense don't always pass muster when tested in the most important test, the randomized controlled trial. This trial was done in 23 health systems, and they randomized patients with hypertension. About 1,000 got standard self-measured blood pressure. Another 1,000 got enhanced self-measured blood pressure with these apps. The primary endpoint was reduction in systolic blood pressure, defined as the difference between a clinic blood pressure at baseline and the most recent clinic blood pressure extracted from the EHR at 6 months. The results, no difference. Both groups had about 10 millimeter drop in blood pressure. Now, this was a pragmatic trial. It enrolled a diverse patient population, and I love pragmatic trial in spaces like this because you want to test interventions as they will be used in the real world. Now, the authors discuss 4 other trials of self-monitored blood pressure, and taken together, they find that they support the idea that self-measured blood pressure reduces blood pressure, but there is minimal augmentation from these digitally mediated co-interventions without clinicians. And my point in highlighting this RCT is that we need more of these things in the digital space. There's a huge movement amongst entrepreneurs and corporations to try to make profits in the health space with these digital technologies. Yet, come on, true health is elusive. And before rendering a gadget as a norm, we ought to be teaching the public that digital devices need to pass muster in randomized controlled trials. Lest the benefit of these devices, like so much of the current screening industry, passes to the device makers rather than the device users. Okay, final topic today is direct-to-consumer advertising. Now, international listeners of this podcast may find this section unusual because there are so few countries that allow industry to advertise directly to consumers, but we do. Direct-to-consumer advertising is very, very common in the U.S. I mean, you see the ads everywhere, TV, airports, internet, even, sadly, in doctors' offices. About a week ago, I tweeted a large frame poster that the makers of Watchmen assumed that we would put in areas that patients would be. Now, you might wonder whether these ads actually work. There are two ways to know this. One is to assume that if a profit-driven company is using them, of course they work, because profit-driven companies don't do things that are of low value. Now, the second way to know if these things work is to actually study them empirically, and that's what I want to talk about. JAMA Health Forum Journal has published a randomized trial of sorts in which the authors recruited about 2,800 individuals from a U.S. nationally representative sample of people who were at high risk of cardiovascular disease. These participants were then randomly assigned to one of three interventions. One, direct-to-consumer advertising for heart disease medications. Two, direct-to-consumer advertising for heart disease medications with price disclosures. Or three, a control group of non-pharmaceutical advertising. Now, each group watched 5 one-minute videos for a total of 5 minutes of advertising exposure. And the primary endpoint was an ordinal measure of medicine and lifestyle-related intentions, beliefs, and brand perceptions. The results were positive, but in some surprising ways. There was a positive association between direct-to-consumer ads and medication-related behavioral intentions, including the intention to switch medication. There was a positive association between direct-to-consumer ads and engagement in information-seeking behaviors. Surprising was that they found no evidence for differential associations with price disclosures in the ads. And there was a positive association with consumers' favorable perception of drug makers. And there was no evidence that direct-to-consumer ads for cardiac medications discourage use of diet and exercise. So comments. The authors highlighted in their discussion and in their comments to the media that the direct-to-consumer ads likely does not affect lifestyle behaviors, and they found that very reassuring. Okay. But I would put emphasis on the other things. First, overall, ads work. Specifically, the drug ads induced people to learn more information, created favorable views of the companies, and set patients off on information-seeking behaviors. Price notification had no effects, which has to be solely explained by many Americans being shielded from price, aka they have no skin in the game. And I feel a tension about this. One side of me sees these as awful. I see the huge effect that direct-to-consumer ads have had in helping ensconce a dubious procedure like left atrial appendage closure. And it gets ensconced as a therapeutic fashion, becomes normal. Patients routinely ask now whether they should have a Watchman, and 99 times out of 100, these are patients who are doing fine either on or off oral anticoagulation. Of course, the ads aren't the only cause of creating a therapeutic fashion. There's overly generous guideline recommendations. There's an embarrassingly rapturous audience of clinicians, many of whom are young enough to be removed from the debate over the seminal trials that were years ago. And, of course, there's the fear of missing out on doing this device. And all of these are on the causal path for creating a new therapeutic fashion. The ads do bolster the change in norms because they change public perception. And this study that I highlight finds that ad watchers feel better about the companies. They create curiosity so that when a person enters a hospital lobby and sees more ads for a Watchman, they feel like, heck, this seems normal. And then they see that big-name hospitals are doing it. So part of my brain thinks that these should be banned. But the part of my brain influenced by Hayek's The Constitution of Liberty, a highly recommended book, by the way, thinks that banning such ads is wrong. The part of my brain that sees the benefit of liberty thinks these should be allowed because people shouldn't be so easily bamboozled. Now, politics and policies are above the level of this podcast, but one of my goals here is to try to inoculate listeners with protection from being bamboozled. Now, just because the hospital across the street is doing a dubious procedure for dubious reasons does not mean you have to do it. Just because patients hear about something does not mean you should do it. If you have the knowledge from the seminal trials, you can stand above the fray and say, you all, this highly popular therapy X, Y, or Z doesn't really seem that great when you look at empirical data. I mean, take sacubitril/valsartan, which is being heavily promoted in these ads. Listeners of this podcast would know that its only positive trial came against mid-dose enalapril. All other sacubitril/valsartan outcome trials have failed to show statistically significant results. And I still use the drug, but I recognize that it could simply be an expensive afterload reducer for patients with heart failure. Okay, before I close, next week I leave for the ESC Congress in Barcelona, Spain. It starts on the weekend. This podcast usually tapes until late Thursday or early Friday, so I'll do some previews next week. Early next week, look for my ESC preview column on the heart.org Medscape Cardiology. And if you're in Barcelona, please say hello. The week following the ESC Congress is usually our Labor Day holiday. Normally, I would take that as a vacation, but since ESC is so important, I will do a recap and take a week off later in the month when I travel for a Grand Rounds talk. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please consider giving us a rating, writing us a review, and I really want to say thank you to the comments on the heart.org Medscape Cardiology website. Last week we had a bunch of comments, and that was really nice. So feel free to make comments, please. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.